So the next speaker is Dr. Priya, and she would be discussing some of these problems where we find it difficult whether it's a cause of visual loss is maculopathy or it's a neuro-ophthalmological disorder.
Good afternoon, all of you. Thank you, AIOS, for giving me this opportunity. And thank you, Kumudini Madam, for including me in this instruction course. So, my topic of discussion is retinal diseases masquerading neuro-ophthalmological problem. So, usually when we have some symptoms like phospins or photopsia, visual acuity loss is not that much, or visual acuity loss is little bit debatable. Visual field defect, usually centrocecal scotoma or blind spot enlargement, and fundus findings are very less. There is paucity of fundus finding. So in these cases, usually we think of that is a neurological problem and we store. So we will see each history and clinical examination is important in differentiating that is a retinal disease or it is a neuro-ophthalmological problem. Initially, one by one we will go to symptoms first. If patient is giving metamorphopsia, metamorphopsia usually a sign of macular disease, that is distortion of object, and usually it can be associated with central scotoma and micropsia. Next is phospin. Phospin means seeing lightning type, but how can we differentiate based on phospin only? If it is a retinal phospin, that is more visible in dark. And why it is? Because of traction of retina, traction of vitreous on retina, and some retinal inflammatory conditions also can produce phospin. But some literature also shows that optic neuritis can also show phospin is reported, and it is more commonly associated in migraine. But how can we differentiate that it is retinal phospin or migraine? Migraine, whenever a phospin is associated migraine, it is usually a hemianopic pattern, one-sided, and the typical fortification spectra or tecopsia, different terms are used. That is one-sided scintillating scotoma, and it is not affected by light, whether you are seeing in dark or whether seeing light. So that usually we can know that it is migraine. Or in retinal phospins, they are better appreciated in dark. Pain on movement, as we know, it is a typical features of acute optic neuritis. So whenever there is no pain, either it is an other ischemic compressive neuropathy or it may be a retinal disease, but not typical optic neuritis. Loss of color perception, as we know, can be decreased in macular as well as optic neuropathy, but in optic neuropathy it will be out of proportion, whereas in macular diseases it will be comparable, degree of vision and degree of color vision. RAPD is there, mostly neuro-ophthalmical, although I can show some retinal disease can produce subtle RAPD, but it is mostly we take that it is neuro-ophthalmological problem. Clinically, then we can do a visual field test. Visual field testing if so enlarged blind spot. This sign is very important. When we see, we know that optic disc edema can produce blind spot enlargement, but for blind spot to be enlarged, the edema should be that much severe to produce constriction of field. If we are seeing fundus examination, either there is no optic disc edema or disc edema is very subtle, mild blurring of disc margin, but we are seeing blind spot enlargement, then obviously it is not due to edema. It is some retinal disease usually affecting the peripapillary retina. And we can do clinically photostress test, very important, simple test, bright torchlight can be seen in undilated eye, and you ask the patient to read before the shining light, and when you remove the source of light and ask the patient the time interval between removal of the source, and patient can read one line above the BCVA, that is the time interval. In macular cone functions, the recovery is very slow, in minutes, whereas in optic neuropathy, it can be around 30 seconds. So from that also we can give a clue that it can be retina. So I have categorized, there are so many diseases, so I have categorized some disease accordingly. One group is, as we can see left side, acute idiopathic maculopathy, acute retinal pigment epithelitis, azure complex, and acute idiopathic blind spot enlargement. I am not going to detail each disease, but some very overlapping common features, that these are acute onset scotoma will be there, female preponderance, usually myopic female, and there will be enlarged, either patient will say central or centrocecal scotoma, and so there can be gas as stated that this should be comprised as azure complex. We can tell, so azure complex is designed for that female preponderance, unexplained vision loss, and enlarged blind spot. Photopsia will be there, ERG. So one by one, just touching this condition, what are those? Acute idiopathic viral prodrome will be there, acute onset unilateral painless vision, and disruption if we do. So we should take the help of multimodal imaging always when you are facing this type of complaint, before jumping that it is a neuro-ophthalmological problem and order MRI and all. So you should do take the help of whatever investigations we have with us. So here we can see there is disruption of the ellipsoid layer, hyperreflective debris, and exudative macula, and it resolve uneventfully in most of cases in 4 to 6 weeks. Acute pigment epithelitis also little bit of same, female preponderance, a flu-like history will be there before, and so these are have overlapping pictures also, and spontaneous recovery is there. Then coming to the azure complex, the original azure acute zonal outer retinopathy, you can see that some zonular retinal effect, and these are all outer retinal disease. Till whatever I have told till now, these are outer retinal disease affecting, as we can see in the OCT, this is disruption of the outer photoreceptor layer, ellipsoid zone, interdigital zone. We can appreciate, and in autofluorescence, a typical trizonal pattern, that means outside area is normal autofluorescence, as we can see right upper picture, and a speculated hyperautofluorescence in the active area, and inside is the atrophic area, that is hypoautofluorescence. So if we do multimodal imaging, we can pick out these diseases even if the fundus picture is very subtle. Obviously, gradually when we follow these cases, they can present with a characteristic pictures like that is grayish-white zone, but initially we may miss this condition. And it has a variant which is called acute annular, that means it is a peripapillary conditions. So we have also one case, this is Kumudini madam. Thank you for madam sharing this patient's data and telling her experience. This patient also was referred from a retina specialist for neuro-ophthalmological workup, and all tests should be done including Leber's hereditary optic neuropathy also. Gene test was negative. So gradually this patient, as we can see, acute onset scotoma was there, and after a follow-up of a period of time, gradually those gray-white zones came to appear, and patient was finally diagnosed azure. So it was a follow-up, and so her experience was that this type of things can be. Also our literature also show this, we can see this multifocal ERG, as we can see this is macular, that peak, macular peak is not there in right side photo, so that is severe macular atrophy. So ERG also an important plays important role in this. So literature also says that these type of cases are frequently misdiagnosed. Like 15 years, they are diagnosed one disease and finally found out to be azure or something else like. Then acute idiopathic blind spot enlargement. How we can tell? There will be a grayish, just let comes to the picture. There's a beautiful picture by Zimmerman et al. We can see that is the grayish halo. You can see the optic disc like a grayish halo it seen. Actually that is the retinal diseases that affecting optic nerve, and you can see with this type of, the edema is not much prominent, but you can see how the blind spot is enlarged. And with sequential, without steroid use is also controversial, you can use steroid or not, but it improves. And so this is acute idiopathic blind spot enlargement. Then coming to the next group, one is acute macular neuroretinopathy and paracentral acute middle maculopathy. Lots of association has been, usually most CRVO, BRVO, ischemic events and viral prodromes, shock, intravenous drug history like epidrapine, trauma, preeclampsia, all these has been associated. There are lots of in literature cases. So we should know these entities also, because they have very subtle fundus picture. If you know these and do the accordingly test, like this acute AMN, it will like a deep dark red lesion, very subtle, pointing to retina. It is the disease of outer retina, mostly deeper, involving deeper retinal capillary plexus, whereas paracentral is the middle, affecting the middle capillary plexus. We have one case, as we can see, this is the 50-year-old male with acute onset scotoma. Vision was not affected 6/6, and our anterior segment findings were unremarkable. So we can see only the tortuous of blood vessels. So we suspected this is grade 2 hypertensive and impending CRVO. And on field also we can find some focal loss area. And in see the OCT, we can see in the middle layer of OCT, right eye, above one first picture is right eye, we have hyperintensity, band like hyperintensities, whereas the comparative compared with the left eye OCT is absolutely normal. So, and it is very dramatic experience. N-phase OCT, macular scan, there is N-phase facility. So if you see N-phase, see the perivenular fawn-like appearance, globular appearance or fawn-like appearance, whereas the B is the normal eye. So we can compare. Very dramatic picture, whereas fundus was absolutely, you cannot see these lesions. And also in fundus autofluorescence and angiography you can do to add this. Last, only I am telling the name because detail will be beyond the scope of this discussion. One is paraneoplastic autoimmune retinopathy, can be carcinoma associated, melanoma associated. So they also affect the outer retina, photoreceptors and outer retina. All these symptoms will be there, like night blindness or photophobia, sensitive to light. So any elderly patient, no history, you may not get a malignancy history, but elderly patient acquired nyctalopia along with, and fundus finding, very subtle fundus finding, you may not early stage fundus will be absolutely normal. So think of some underlying malignancy and do workup accordingly to find that malignancy. So this is the paraneoplastic autoimmune retinopathy. And toxic retinopathy, as we all know, there are lots of drugs, vigabatrin, chloroquine, and definite screening protocol is there for all drugs. So we should take the drug history also. It may be a side effect of the drugs. And finally, retinal dystrophy. As we know, these are obvious manifestation in later stage, but in very early stage, especially when sign pigmento, sectoral retinitis pigmentosine, where pigments are not that very clear, or any other dystrophy in early stage, they can also mimic this type of neuro-ophthalmology. So we should, if we know this entity, if our mind knows, then we can do the workup. We have some equipments in our hand, so we can do this test and clarify what the disease is before just jumping to or sending to neurologist or ordering an MRI or all this. Thank you for your kind listening. So always take the help of this. Thank you.